Hello everyone, I'm Rashed from Bangladesh and I'll be presenting our paper titled Dakter Bari Introducing Intermediary to Ensure Healthcare Services to Extremely Impoverished People. This work is in joint collaboration between Bangladesh University of Engineering and Technology BUET and University of South Florida. Before I begin, I'll start with a little bit of background and motivation of our work. People that depend on alms for a living are extremely impoverished. In many Asian countries, these people are sizable in numbers. In Bangladesh, which is a developing country, there are more than 700,000 peoples. Throughout this paper, we identified them as extremely impoverished people or EIPs. EIPs are generally deprived of many fundamental needs including food, clean water, shelter, access to sanitation, healthcare services, and many more. The focus of our work is their access to healthcare facilities. Prior work shows that whenever an EIP gets sick, he does not end up visiting a doctor. 28% of the participants in that study suggested that there is no need to visit a doctor during sickness, since they believed that their illness would naturally disappear. Another 20% reported that dependent on amulets, holy water from religious leaders. However, despite the reluctance of EIPs to visit clinics, there are organizations that provide cheap and sometimes free treatment services to low-income people. For example, J.H. Shikdar Medical College in Dhaka provides free healthcare and treatment on every Friday to low-income people. Dhaka Medical College, on the other hand, offers diagnosis every day for a fee of only 10 Bangladeshi taka. They also provide some medicine free of cost. Although EIPs are intended recipients for these services, these cheap healthcare options mostly remain underutilized and unknown. There happens to exist a clear information gap between cheap or free healthcare services and the people that desperately needing them. Our primary focus in this research paper is to bridge existing information gaps between healthcare and resource-constrained people that desperately need those services. To do so, we first did a qualitative interview-based study with members of those EIP communities. We identified possible options to avail healthcare services for this community and their challenges through another interview-based study with hospital partners. This part of our study was guided by our first research question. To answer this question, we identified the technological endpoints in the path from the hospital to the EIPs, their social connections, preferences. Based on the findings of this part, we identified technological intermediaries and asked whether we can leverage technologically connected intermediaries or facilitators to close the information gap. As mentioned earlier, our study consisted of two-phase interview rounds. In phase 1, we conducted semi-structured interview with 70 EIPs in Hazaribagh and Azimpur slums. Only 6 of them had print literacy and only 7 had access to a feature phone, with the rest having no access to smartphone or any kind of smart devices. During this time, we also started collecting information regarding free treatments, beds, medicine, and surgery offers from local hospitals in Dhaka. The interviews were conducted with hospital officials in the hospital premises. Based on the findings of these studies, we then interviewed another 71 intermediaries coming from a variety of socioeconomic status and professions. Mostly we visited pharmacies, grocery shop, mobile recharge shop owners, and tea stallers. Now let's quickly look at some findings from our field studies. Hazaribagh and Azimpur slums, where our participants live, are full of tin-shed houses. Each slum has around hundreds of homes. In a single room there, usually 5 to 8 EIPs live. While some of our participants mentioned residing with their families, others lived with non-family members in that very single room. One important feature of this community is their nuanced social connections. As a group, they meet up with their peers from the neighborhood and decide where and how to seek alms on the next day. Our participants have deep social connections beyond what was presented above. EIPs interact with local shopkeepers like grocery merchants, tea stallers, pharmacists regularly. Our participants found that their connection was useful to them in many ways. Another important aspect that we found is a detailed description of what happens when these participants fall ill. For instance, one participant told us that Allah will heal her ailment because He is the one giving the ailment, and it is at His wish. Another said that this boy at the pharmacy understands my symptoms better than anyone else. He gives me medicine according to what I earned that day. It is important to note that in Bangladesh, buying medicine from local pharmacies does not require any prescription from a doctor. In the absence of essential infrastructure, social and civic support, we learned that EIPs create a social network among themselves that allowed for quick and strategic information sharing. The similarity in economic status, life experiences, and group-like economic activities assist the formation of such network. This is a small snapshot of hospitals we visited and the types of services they offer for the poor people. For instance, DMC offer outdoor consultations for as low as 10 taka, and this is available daily from 8 a.m. to 1 p.m. Hospital personnel also shared with us that these offers and sometimes free medicines mostly remain underutilized. This is especially true for non-regular offers coming in a monthly or yearly basis. Our possible intermediary partners had above-average print literacy and internet smartphone proficiency. 51 out of 71 participants mentioned having smartphone and being used to the internet. However, they come from a variety of socioeconomic status and their job nature varies a lot. For example, local tea stallers have to open their shops at around 7 a.m. and have to close after 11 or 12 at night. In general, they had better socioeconomic status, literacy, and technological awareness than EIPs. They mentioned having good relations with armed dependents. One pharmacy owner puts the reason like this: what will you do when an arm seeker asks you for medicine when he can only afford 5 taka? I understand these people and their health just like my finger. Overall, we found a philanthropic intent of intermediaries toward EIPs. So when we asked whether they would be willing to help in any ways without receiving any monetary incentives, the general response was positive. When participants went on to say that he will collect reward from the God and he will already give a sizable amount of money to the poor, and he'll be happy to help if that will bring free or cheap treatment to the needy ones. From our study with both these groups, we observe a few things. First, the fact that pharmacy and grocery shops are permanently open from morning to night makes them way more accessible compared to other groups. Second, the existing interplay between EIPs and intermediaries is based on care, social fabric, philanthropic intent. So it might be possible to use pharmacy and grocery shop owners as our information intermediaries. The simplest and most obvious idea was to design pamphlets and distribute them among the intermediaries so that they could read out all those offers to an EIPs. While this solution would meet our needs, the scope for this non-tech solution was significantly limited because offers from hospitals are subjected to change and including cancellations in special days. So there is also need for instantaneous adaptability, such as incorporating time to travel, distance information. So an application-based system is a better fit for this response. So considering all these, we propose our system model. When a person is in need of hospital information, she should visit an intermediary having a smartphone. The intermediary with the app installed in his or her phone sends a request that includes the EIP patient's name, information, and symptoms. Our web server will receive the request immediately and sends back 2 different responses: the cheapest healthcare option and the nearest hospitals. We developed our Android-based system named Dakter Bari, which is a term in Bengali that translates to doctor's home. We also developed a web portal for hospital staff to add available or free, low-cost healthcare offers through this portal. We deployed our initial release to 11 intermediary partners. After a small user testing phase of 2 weeks and iterative improvements with 11 intermediary partners, we deployed our system to 9 more partners, resulting in a total of 20 intermediaries. Now we share some of the major themes that emerged from the feedback we received after the deployment of 7 months. We also share how our application design changed based on the feedback of both intermediaries and EIPs. Initially, in our app, we kept the field for intermediary partners' phone number. In the testing phase, we removed that as intermediaries were having trouble to repeat the number for each request. Another intermediary was trying to use the app after turning off GPS, and the app was failing to send any request. Then we made the location access mandatory to use the app. We observed some interesting phenomena during this period. For instance, some of the participants said that once they visit a hospital for the healthcare they need, they're likely to visit the same hospital again. This is irrespective of the suggestions receiving from the app. When participants mentioned that she liked the hospital and the doctor in the PG hospital, so she wanted to go there again. We also found some intermediaries suggest hospital without using the system, memorizing the earlier recommendations. We saw that credibility of the intermediaries can suffer as a result of erroneous recommendation. Our system was also used beyond our intended use cases. For example, EIPs suggested other communities such as rickshaw puller cleaners in the slum to use our system, and intermediaries used our system for their families and friends. Our study has several key takeaways for the CSCW communities. First, our insight on economic and social support, healthcare, and related finding in this paper can have strong implications on further design of ICTD interventions for a wide class of economically disadvantaged people. Our data from both the EIP and potentially intermediate studies show that there is a symbiotic relationship between these groups, both in terms of taking arms and purchasing necessary items, and we add a layer of the voluntary healthcare services to this relationship. Unlike the traditional intermediary literature available within the CSCW domain, we call for different approaches and modes of tech intermediation depending on the appropriate context. So if you have any questions or feedback or ideas for our work, feel free to send me an email. I'll be happy to discuss. Thank you, everyone.